Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast, and I'm Dr. Andy Cutler, and today we have a topic, actually a couple of different topics that we just don't hear enough about. And with me today is Dr. Pamela Wall. Pam, hi, how are you?
Hi, I'm well. Thank you for having me, Dr. Cutler.
You bet. And tell us just quickly a little bit about your experience that's relevant here, if you don't mind.
So I am a psychiatric nurse practitioner. I am a 20-year veteran of the United States Navy, and I'm also an associate professor at Rosalind Franklin University.
Mm-hmm. And so you've worked most of your career with the military or with military patients?
I have, yes. So I've worked in the Department of Defense. I've also worked in a PTSD TBI clinic in the Durham VA. And many of my patients in my civilian practice are veterans.
Got it. And you were sharing with me a minute ago, your husband is a special operator, so you work with this and live it.
Yes, I do.
Okay, great. Well, speaking of military culture, maybe you can tell us, just help us understand, how does military culture, things like the stigma, the chain of command, expectations to be tough, how does that shape trauma and PTSD and how they present?
So I want to frame this by kind of talking about an overarching theme, and that's that the military is really all about rules and regulations, and everything is framed by congressional mandates. The number of people who serve in the military, that's determined by law, and this is really important when we think about military culture and stigma. The military has this ethos. It's a warrior ethos. It's a group collective. It really earns supremacy over an individual thought. And this is guided by military training and experiences. It's this idea that the mission comes first over one's own needs. You never quit. You don't leave anybody behind. There is zero failure. You have to be perfect. You have to stay tough, no matter what you experience. And this idea prevails through all decisions, including how you seek healthcare. If you have to leave to address your own healthcare needs, you're leaving that mission behind. And I'm going to explain this a little bit more in detail. So remember, the number of billets or people who serve in the military, that is set by congressional mandate. We can't go more or less. It's set in stone. And if somebody becomes ill or injured, there might not be a replacement for that individual. And that individual might be in a mission critical billet. So there is a decided command interest in maintaining their mission readiness. They have to be ready to go at any time. That's our job in the military. It's a very intrusive mindset, and it creates a significant stigma when you are thinking about seeking healthcare. It's not just mental health care, it's any health care. So there's a decided reluctance to go to medical, go to the wizard, as they would call us, because you go there, you do the wizard, and you don't come back. If you seek mental health care, you might be perceived as weak, and the commanding officer by UCMJ has the ability to know if any of their service members are out due to the impact on mission readiness. So this definitely is going to impact on how someone is going to present with trauma or symptoms of PTSD.
Wow, that's just a lot of pressure. I can imagine. On top of whatever else you're experiencing, there's this constant pressure. And so I can also understand why someone would be reluctant to try to get help and internalize it and think somehow I'm weak or I'm a failure, or I'm letting others down.
Yes. there's this idea that you just rub some dirt on it, take some Motrin, and change your socks, and you're good to go.
Oh boy. Okay. Well, that's really helpful. Thank you for those of us who are not in the military or not around it. There's a lot of misperceptions, I think, around PTSD and what kinds of trauma are required or lead to it. And so one misconception might be that we're talking about a single incident and that's what causes your PTSD versus cumulative trauma. Could you talk a little about those issues?
So I want to kind of conceptualize this cumulative trauma. There's a number of different terms floating out there for cumulative trauma. And I want to pay homage to Dr. Judith Herman, who really has been recognized for her contributions of understanding and really talking to us about this cumulative trauma. And she conceptualized it as PTSD, complex PTSD. And then her work really went to identifying this condition. We call it DESNOS, or disorders of extreme stress not otherwise specified, in DSM-4. What we have now is evolved to two different definitions. We have the ICD-11, or the World Health Organization, where you have PTSD, and then the next layer of symptoms, they define it as complex PTSD. And then in the DSM-5 TR, you have the specifiers, which are the complex specifiers. So everything is under the umbrella of PTSD. So there's a couple of different ways to think about this. But in general, cumulative trauma is considered as multiple traumatic events, such as childhood sexual abuse, or prisoners of war, or people who have experienced prolonged trauma. Consider our service members who were in World War II, and they went over for years at a time and were exposed to multiple prolonged trauma. So that would be considered that prolonged trauma, that cumulative trauma.
Yeah. How good do you think we are at recognizing these causes or these precipitants?
I'm not sure how good we are. I mean, I was looking for evidence to see if we're getting better at it. I don't have any evidence one way or the other. But what we do have are a number of resources available now that I'm not sure that we had before in identifying cumulative or complex trauma. So the National Center for PTSD, you can find this via the National Center for PTSD or through the VA website. They have a lot of valuable information on how to assess and treat cumulative or complex trauma. And then there's a great tool that can be used. It's called the ITQ-5, which is and I have to look at the name of it, so it's called the ITQ-5, International Trauma Questionnaire. And it's an 18-item self-report questionnaire, and we all know that there's might be some validity issues with these self-report questionnaires. However, it divides out between PTSD symptoms and then these disturbances of self-regulation, which are more known to be that cumulative trauma symptoms. And that's really helpful for clinicians to decide what they're really looking at.
Well, that's terrifically helpful. Thank you very much. And just so you know, at later this year at the NEI Fall Congress, I'm going to be doing a talk with Lori Davis, who you probably are familiar with, on PTSD. Lori's at the VA and at UAB in Birmingham, Alabama, and has been working in this field for many, many years. Is a wonderful person. I've learned so much from her over the years. So I will encourage people, of course, to come or view it virtually, or you can obviously get the replay of it, the encore. And the reason I'm saying that is we're going to also now shift over and cover TBI a little bit, and especially many veterans can have both. You can have PTSD and TBI, either because the traumatic brain injury event is what caused your PTSD, or they could be separate. Tell us a little bit about how they interact, and maybe how can we sort this out and try to help someone who has both.
So I want to focus on mild traumatic brain injury because really about 85% of veterans have mild rather than the moderate or severe brain injury, and that's what most of the literature speaks to. And so we know that mild traumatic brain injury, there's the primary injury, and then there's that secondary inflammatory soup, as I would call it, that results in some, secondary injury to neuronal injury. What's interesting, and I kind of want to pay homage to this, is that there's a lot of differences between civilian PTSD and TBI and military PTSD and TBI. And I think it has something to do with the types of exposures, because military is more likely to be exposed to what's called blast TBI. And blast injuries have a very different exposure to those pressure waves. And so people in the military are 4 times more likely to have PTSD than civilians, who are about 1.26 times to have PTSD with the mTBI. So there's a higher risk for that comorbid diagnosis when you think of military versus civilian. There are some functional neurological changes that occur in people who have both PTSD and TBI. There is left hippocampal volume depletion. There is increases in amygdala. And then there's decreased cortical thickness. And when you think about the symptoms that are present, people with brain injury, particularly mild brain injury, they have cognitive changes, they have pain. And if you have those two, it's very hard to do CBT. They don't have the cognitive capability or willingness to do those evidence-based therapy. And on the other hand, when you have PTSD, it's hard to build trust. There might be some comorbid substance use going on. And so they might have a decline in those health-seeking behaviors, which might go to a decline in health outcomes. So there is definitely a risk with the two together.
Yeah. Yeah, no, it sounds like it's a lot more serious when you have both at the same time. And I hadn't thought about how the changes in the brain could influence your ability to seek help and to get treatment. But it does help understand some of the symptoms you might see. This lack of kind of frontal control and cognitive control if you have less, a thinning of the prefrontal cortex. I'm sure you're disrupting the top-down neuronal communication. Larger amygdala, to me, of course, fits with PTSD. Their alarm system is on overdrive, if you will. And then the hippocampal problems, that's obviously memory and cognition as well. So that's very interesting that they all fit together like that. Now, for clinicians out there, whether they're dealing with someone in the military or not, what could be some flags that you're dealing with undiagnosed TBI complicating the PTSD?
So what they have shown is that there is some impaired long-term working memory and cognitive flexibility, and that's been shown in neuropsychiatric findings. But some big red flags that I would look for is the pain, the headaches, the dizziness, noise, and light sensitivity. That's very particular in mild traumatic brain injury that I would notice in somebody who's not been diagnosed. So I'm looking for somebody who's walking in with sunglasses. They have headaches that are untreated. Those are the things that I'm going to look for. Most individuals who experience mild brain injury, those symptoms are going to usually resolve within 3 to 12 months. But some individuals, especially with comorbid PTSD and TBI, those symptoms can go beyond that. So those are the things that I'm going to look for.
That's extremely helpful. And for me, perhaps the one I hadn't thought of was the pain idea, not just headache, but pain. I actually remember treating a very famous NFL player who was a defensive lineman and told me he had tons of, on the line, you're banging your heads all the time. And he had chronic pain as part of his presentation. And he told me, he said, I laugh when I hear about people who play sports occasionally getting concussions. He said, I had 4 or 5 a game. I just didn't tell anybody. And that is that warrior mentality, I guess you're talking about, because he was afraid if you told somebody, they would take you out of the game and you wouldn't play or you'd get replaced. So that chronic pain, and also he had a lot of trouble with insomnia. And I'm guessing that's a big part of this too. Am I right?
Yes. Yes.
Okay. Well, that was really helpful, those signs right there. Now, speaking of insomnia, sleep disturbances, of course, are common to both. So what are some approaches you found helpful in, fully assessing this and then treating this?
So as far as assessment, what I'm going to do is I'm going to evaluate how that sleep disorder started. So I'm going to look at more of a linear approach. When I talk to a patient, I'm going to say, what is the first symptom that you remember having? And especially with somebody with cumulative trauma, with head injuries, I'm literally going to go back all the way to possibly childhood, what came first. So I'm looking for the first symptom that you experienced, anything that they experienced with it. So if the sleep problem came with the trauma, that's going to be a very different treatment algorithm than a sleep problem that came with a brain injury. So those are the certain things that I'm going to look for when I'm assessing a patient. And then a normal sleep evaluation is, what are you doing before you going to bed? What are you doing when you're in bed? Are you playing with electronics? Are you watching TV? Are you laying in bed all night wide awake? What are you drinking? What are you eating? Are you showering? These are normal sleep hygiene things. When's the last caffeinated beverage? Are you using a lot of alcohol? So normal sleep assessment techniques. The other thing I'm going to look for, especially in a patient who has brain injury, is sleep apnea. A lot of people don't know that sleep apnea is affiliated with brain injury. So I'm going to look for morning headaches. I'm going to look for daytime sleepiness. I'm going to do an Epworth sleepiness scale assessment, snoring, gasping for air. And then if that is warranted, I'm going to send them off for a PSG or polysomnography to see if they have sleep apnea. There is a lot of data out there to suggest that service members, veterans, anybody who has head injury are at a higher risk for having sleep apnea. So those are the things that I'm going to look for.
Wow, incredibly helpful. And that tip about sleep apnea is really important because I imagine the person does not have to be overweight or obese because the head trauma itself causes the pathology. Am I right?
Yes, and that's what led me to go get my dissertation, because I was working in the PTSD TBI clinic at Bethesda, which is now known as Walter Reed. I was seeing a lot of these young, healthy males who were having sleep apnea, and I didn't understand. The Mallampati score did not match. They were not, they didn't have the neck. They didn't have the BMI. And I said, I don't understand why this is happening. So that's what led me to do my research at Penn.
Oh, how cool. So that's really cool that was what you studied. That's another comorbidity that people probably are not aware of. So another helpful tip. And also, I think your tips about assessment were fantastic. Something that we do too in research sometimes with rating scales is you'll look at, is this initial insomnia, middle insomnia, late insomnia, or some combination. And as you said, what's happening while you're not sleeping? Is anxiety, rumination going through your brain or what is it exactly? So now let's talk about, I guess, addressing that. What kinds of interventions are helpful for especially treating sleep?
So I'm going to go back to all the clinical practice guidelines and the American Academy of Sleep Medicine, and really what they recommend for any type of insomnia is good old-fashioned CBTI, sleep restriction, behavioral mechanisms to manage their sleep. So those are the first, and those are the least, they're not going to cause any harm, especially to somebody with a brain injury. I'm very reluctant to prescribe medication with somebody with a brain injury because I really don't know how diffuse the injury is going to be. So my first go-to is always a cognitive or behavioral approach to that individual. If I do have to prescribe medication, I'm going to go to melatonin. Melatonin has some neuroprotective effects. It's not FDA approved for insomnia. It's FDA approved for circadian rhythm disorders. But again, I'm going to go to something that's going to decrease neuroinflammation. So melatonin is, or Ramelton is going to help with that. So those are the two that I would choose for a brain injured patient with problems. Usually sleep onset it's not going to help with sleep maintenance. So those are the two that I'm going to think about. If I have a patient who has a mood disorder and a brain injury, I'm going to probably think about trazodone. That is recommended by the American Academy of Sleep Medicine for sleep maintenance in comorbid conditions. There's no evidence to support that with brain injury, but again, I'm just going to stick with managing the sleep disorder because the clinical practice guidelines really tell you to manage the sleep disorder independent of the brain injury. And when I'm prescribing, I usually cut the initial dose in half, and then I titrate very slowly. So I start low, go slow.
So you found people with brain injuries to be more sensitive to medications in general? Is that what you're saying?
They can be, but that's what I was always taught is start low, go slow.
Yeah, that makes sense. In my experience, that has been part of my experience, though. People with brain injuries seem to sometimes be a little more sensitive for whatever reason. And speaking of which, we've talked, I think you've talked a little bit about assessment for each of these individual things, but let's talk about an assessment process. A veteran comes in and they may have PTSD, TBI, and sleep problems, this whole stew. How would you assess that person? Are there certain tools or screening instruments? You have mentioned the ITQ, but what's the way we would do that, assess a patient?
So the assessment for a brain injury is pretty involved. There are a couple of assessment tools that you can use to help guide your conversation. One that I like to use, especially in military veteran population, is something called a MACE. It's what they use to evaluate a service member out in forward operations. And so this tool will help you to evaluate the type of injury, and it also includes a blast injury. So you start off with very open-ended questions. What happened? Where were you? What were you doing? Who were you with? And then it goes on to explore the type of injury. So, for example, let's say you have, I don't know if you want me to go into this level of detail, but let's say you have a service member who was in an infantry unit and they were walking and they were close to a blast injury. And so one of my questions is going to be where were you in relationship to that blast? Was that blast in front of you, to the side of you, in the back of you? Because that's going to determine what area of the brain is going to be affected and what type of symptoms they might manifest. If it's a blast, you're also going to look for debris injuries. Was there anything in between you and the blast, such as a Jersey barrier? A Jersey barrier, those big concrete barriers that they sometimes put up to help protect service members. Was there a vehicle in between? So I'm going to look for debris injuries. I'm going to look for mitigating factors, such as those Jersey barriers. How far were you? Were you thrown due to the pressure wave? Did you lose consciousness? If so, for how long? Did you have problems with memory? Were you lying flat? That's an important question because people are like, I don't remember. If you were lying flat, chances are you lost consciousness. So you ask these very detailed questions to try to piece together the event. Did you have scattered memories? So sometimes people will say, I have kind of flashes of memories of waking up here and there. And then when do you really remember having a linear memory of what happened? What kind of symptoms did you experience? Did you have a headache? Did you have ringing in your ears? Did you stumble around? Did you feel like your bell was rung? What was it like during the first 24 hours after injury? And then another important question is, did you seek health care? A lot of these service members didn't seek health care, wouldn't seek health care, didn't have access to health care. So they just turned right around and went back out and possibly were exposed to a secondary event. So those are other important questions to ask. So that's a typical assessment for a blast injury.
Yeah, that's super helpful. And it kind of comes under the dictum to be a good clinician is to be curious and ask a lot of questions, I guess, and get, the details, the particulars. Now, how about the PTSD part? How would you assess the PTSD and the two together, how they interact, I guess?
So for PTSD, especially in combination with the blast injury, there's a lot of thought that, well, if you didn't remember the event, you're not going to have PTSD. I don't necessarily agree with that. And so I'm going to ask about pre-existing trauma. I'm going to ask about whether or not if there was a blast. Often, and I will just give an example. Let's say you're a driver in a vehicle and you were exposed to a blast maybe underneath the vehicle. And here's an example where a blast and PTSD can very much coexist with one another. I hear stories many times where a driver switched sides with another individual, and the person that they switched sides with was the person who was killed or injured significantly. So then there is a significant amount of guilt, self-blame, self-recrimination that really leads into the expression of that post-traumatic stress disease. And so those are the things that I'm going to ask about in that question about those hypervigilance and those negative beliefs that they have, especially those negative beliefs that they have after that event.
Mm-hmm. Wow. Yeah, that's also really helpful too. And you mentioned something interesting here, something I've always wondered about, and I don't know what your thoughts are on this, is a lot of people are exposed to traumatic events, but they don't all get PTSD. So there must be some pre-existing vulnerability, whether it's genetic or, as you mentioned, prior trauma, and maybe this is cumulative. Do you have any thoughts about that, about why certain people get PTSD and some don't?
So the research is very clear that there is certain risk factors on the development of PTSD, being younger, being enlisted, having pre-traumatic exposure to childhood trauma, and pre-existing mental health illness, but also during the event. If they have dissociation during the event, if they feel a lot of guilt, if there's not a lot of support for them after the event. So I think there's a number of different factors that can happen. I will give an example. I like to tell stories, and I don't know if that's okay here, but there's a story of a service member, and I have to take out a lot of things just to maintain privacy, but a service member who was taking care of another service member, and they were told that they did not do enough to help that service member. And so this led, and they did a great job taking care of that injured service member, and they got them safely back to care, and everything turned out okay. I mean, they were injured, but they survived. But that one thing, that lack of support, was the one thing that led to the expression of that post-traumatic stress disorder. So there are things that can happen after the traumatic event that can create the opportunity for the expression of the disorder.
Yeah. No, I appreciate your stories, by the way. Stories are really how we communicate with each other. I mean, statistics are important and helpful, but I think our brain is wired to tell stories and hear stories. So, and they're very illustrative. So thank you. Okay, we talked a little bit about some interventions, and of course we divide into pharmacological and non-pharmacological. And you and I were chatting earlier about the fact that there are so few FDA-approved options here for PTSD or for TBI for that matter. And so we are sort of trying to do the best we can, ideally with at least evidence-based. So what would you say are some evidence-based interventions that make sense here for people who are struggling with both of these conditions?
So the evidence-based interventions for the trauma and for the PTSD is, of course, the psychotherapy. And we have the EMDR, the eye movement desensitization, prolonged exposure, and then the cognitive processing therapy. But again, if they're experiencing a lot of pain or cognitive difficulties, they have to get to a certain point where they can manage that. For the brain injury, it's symptom management. So it's very detailed, and I think it's beyond the scope of this podcast on how we manage each symptom individually. But there's cognitive rehabilitation, there's pain management, there's a number of different things that we can use to manage each symptom of the brain injured patient. For sleep, as we've said, we can use the melatonergic agents. And then sometimes when I'm seeing a patient and then I have a patient who is experiencing a lot of pain and mood and issues with brain injury, one of the things that I do like to use is amitriptyline. It's not FDA approved for PTSD, but I do like to use it with my brain injury patients. And then, of course, for PTSD, the FDA approved paroxetine and sertraline for the treatment of PTSD. But that's just symptom management. The true movement is with those therapeutic interventions.
With amitriptyline, are you concerned about the anticholinergic effects that it could have? I'm assuming you're using it partly for the pain part of this.
Yeah, there are some side effects, and I wouldn't want to prescribe it with anybody who has some suicidal thoughts and ideations. So there are some implications with the amitriptyline, and again, I would use very low doses. But there have been shown some cognitive improvements with patients with brain injuries with the amitriptyline. It's not an evidence-based, or it is evidence-based. There is recommendations as far as there's information in the literature and the evidence to support amitriptyline. But again, it's not something that's used for PTSD.
Yeah, that's fascinating because I would have thought there's anticholinergic effects that could be cognitively impairing, but of course there's other effects as well. And then you mentioned earlier when you're talking about melatonergic agents, there's an older one called Ramelteon, you mentioned, that many people may not know about, but it was a branded drug at one point. It is a melatonin agonist, and it's generic, so I'm fascinated that you use that. That's very creative. I like that idea. I want to also mention, what we didn't talk about here is the role of atypical antipsychotics on the one hand and anticonvulsants on the other. And I'm going to start with the latter first. That football player I was telling you about had a very good response to lamotrigine, believe it or not. Now, he had a lot of mood instability and pain, and it just seemed to help both of those. So what are your thoughts about any convulsants for these folks?
So I do use anticonvulsants a lot with the patients, and it's an off-label treatment. It is not recommended against or for in the clinical practice guidelines. It's neutral, but I do find that the anti-inflammatory effects is very helpful. And I really love the mood stabilization. I love it for the patients with trauma because I tell them, and this is what I tell them it takes the scratchy away from their brain. It really helps to decrease that noise in their brain. So I really love that medication. It has very low risks except for the rash. However, I find it's a very easy drug to use. Although I explained to them it's very off-label for these conditions.
Yeah, so that's lamotrigine, and there are other anticonvulsants, of course, that would perhaps make sense. I know people sometimes use, for instance, Neurontin or pregabalin. Gabapentin, is the generic name, or pregabalin. And people have used valproic acid, although to be honest, valproic acid has a lot of issues, especially if you're talking about anybody of reproductive age. There's newer research that suggests neurodevelopmental issues and all of this, so I'm a little concerned about that. Okay, now let's talk about the atypicals before I throw you my curveball, okay? The atypicals have a lot of evidence, and sadly, just recently, some of our audience may be aware, Brexpiprazole, they did clinical trials. They submitted the data to the FDA. I was an investigator on one of these trials. And just recently, sadly, an FDA advisory committee voted 10-1 against approving it. And as you've said, the only two treatments approved are two SSRIs. We desperately need more treatments. But as I said, atypicals have an evidence base. And what has your experience been? Do you sometimes use atypical antipsychotics?
I also use atypical antipsychotics in patients with brain injury and PTSD. If I am with a person of reproductive capabilities, I'm probably going to go with lurasidone, just because of it's generally considered safer. However, I find that the additional mood stabilization is very, very helpful in these patients. And again, as you have said, we have very few FDA-indicated medications in this population. So I really wish we had more in our toolbox to help these patients.
Yeah. Yeah, it's interesting because I one of my previous podcasts, I had a woman named Jennifer Payne on who was a reproductive psychiatrist. And of course, the topic of what drugs are relatively safe to use during pregnancy always comes up. And she was saying, interestingly, the atypicals as a class are probably relatively safe. And I know back when we had the ABC system, lurasidone was, considered a B, and all the others were Cs, except, interestingly, clozaril was also a B, meaning relatively safer. And that just comes from animal studies. We don't know about humans. But I just found that interesting. So, any of them certainly make sense to me. Some more than others, and one of the reasons why brexpiprazole is interesting, it has very high affinity for alpha norepinephrine receptors, and PTSD, let's face it, is overarousal, and it's especially your sympathetic nervous system, your warning system on overdrive, and that's largely norepinephrine mediated. So it just seems to me like toning down the norepinephrine system makes sense, and there's other atypicals that have some of those properties too. There's a literature on quetiapine, for instance. I know people have used aripiprazole and so on. Okay, you ready for my curveball?
I am.
What about stimulants?
I use stimulants in patients with mild traumatic brain injury and have cognitive difficulties. Yes, I do use Ritalin.
Okay, very interesting. So methylphenidate. Yeah, there actually, I think, is a little bit of a literature base on that. And talking to my friend Lori Davis, the woman I mentioned earlier, she said her dirty little secret is that she sometimes uses stimulants, and there is a database on that. And it's funny, she mentioned methylphenidate in particular, like you did, and apparently there's a study. She's just submitted a grant, and she's going to be part of a study looking at that. So I think for, and of course in the right patient in the right place, and particularly if they are mood stabilized with either an anticonvulsant or an atypical antipsychotic, you're probably fine. You're not going to necessarily precipitate mania or psychosis or something like that. So you handled that well. You handled that curveball. You're a good curveball hitter, I think. Okay. We have with our remaining time, I want to talk to you a little bit. We need to address interdisciplinary collaboration, of course. Obviously, there's going to be a lot of people involved in their care. So what would an ideal care team look like?
So I envision this. There's this place called NICO up in Bethesda on the Walter Reed campus. So when I envision PTSD TBI team, I always think of the NICO Center. So it is a center that is dedicated to the management of a patient, a veteran with PTSD, TBI, and that includes your primary care manager. This would probably be the ideal team, is your primary care manager is at the center of that. Well, let me rephrase, the patient is at the center. And then you have your primary care manager, you have your mental health team members, you have your occupational and physical therapists, you have definitely neurology, you have a case manager if you can find one. They're sometimes hard to get. Sometimes chaplain or faith-based organizations are very, very helpful. So these are all the little pieces to the puzzle. And then also think about the family member or the caregiver this is very stressful to the family. So any caregiver support systems is going to be involved in that team around that patient.
Well, that's really helpful, and I appreciate you mentioning a faith-based that can be very helpful to some people, religious support and spiritual, I should say, support. And I really appreciate you mentioning the caregiver. We know that there's a lot of stress and strain on the caregiver, the family, the loved ones, and so definitely checking in with them, I think, is really important. Okay, let's talk about common pitfalls or misconceptions that you see. And I'm sure you see a lot of them amongst our colleagues. What kinds of ones do you see, and how can we avoid those?
So I think some of the pitfalls are just in maybe provider bias. There are assumptions about military experiences. As a female veteran, I've experienced this myself, and I don't usually like talking about myself, but it is making sure that they understand that each veteran has their own individual and unique experience. Not every veteran has the same experience, and it's really helpful just to assess their very unique military occupation, their experience, how they thought about it, why they entered, what happened when they left, their transition, and their thoughts about their military experience. It's very helpful not to interject your own personal biases or assumptions into that conversation, because that can erode that therapeutic relationship. Remember, you have this potentially cranky, very mistrustful, and I hate to, use a pejorative, but sometimes the veterans can be very mistrustful of healthcare and the healthcare system based on previous experiences. And so they just want to come in and know that they are in a safe and trust their provider to do the right thing for them. So they don't want that intrusiveness that they've experienced in the previous lifetime, and that this is a confidential conversation. So this is a really helpful thing to do. And then just listen.
Yep. Be curious again. Be curious and non-judgmental. I think if we're smart enough to listen to our patients, we learn from them too, don't we?
Yes.
Yeah. Okay, how about other misconceptions people might have? I mean, one I can imagine is that people somehow think that the person did something to bring it on themselves, or I don't know, other kinds of misconceptions.
Yes. So again, especially with patients with trauma, there is sometimes this idea that if you had done this, you wouldn't be exposed to this. So again, listen without judgment, assuming the best of the patient, and making sure that they are able, it's just simple trauma-informed care, just letting them tell the story from their own particular lens and not making any assumptions about what happened or why it happened. And then in war, people do things that other people may not agree with. And again, not injecting your own personal opinions into that, because there may be this horrible sense of guilt that they feel about this, but just accepting them as they are in that space in that moment. So these are invisible wounds of war. And that's what they have been calling them, because you can't see it. You can't do a test. There's no blood pressure that you can take that shows that they have this. And the traumatic event is very subjective. One person's trauma is another person's not a big deal. And so accepting that person's trauma was very definitely traumatizing to them. And mild traumatic brain injury, you can't see it. There's no CT that you can show mTBI. You often can't even see it on an MRI. So you have to really listen without judgment and believe them that these are the symptoms that they're experiencing.
That's such good advice. Thank you. I sometimes say, we don't have a blood test or an X-ray, unfortunately. So it really is your clinical skill that can recognize and having a high index of suspicion. Okay. You've given, gosh, it's almost funny to ask this next question. You've given me so many clinical pearls and practical tips, but is there another one or something you could boil it down to that you wish every mental health provider knew when working with veterans facing these challenges?
So I guess the one thing that I would recommend is military cultural competencies. A long time ago, Doctors Biden and Mrs. Obama launched something called the Joining Forces Initiative. And this was to develop military cultural competencies in all the schools of medicine and all the schools of nursing, because they really felt that it was quite imperative for all of the healthcare providers to understand the veteran and military experience. And so I really wish, if I could have any wish at all, was for all the healthcare providers to have some level of military understanding. So not everybody is a soldier who works in the military. If you call a Marine a soldier, that's an automatic, oh, there's the hand. And so these are just basic competencies that I think would be very helpful in initiating and continuing that conversation, because most healthcare by veterans is not done in the VA. It's done by civilian providers, because our veterans may have functional difficulty with getting to the VA, may have difficulty accessing care in the VA, may not have access to care, like they may not rate care in the Veterans Administration. So most care is done by our civilian providers. So I think that's the one thing that I would wish for.
Well, I think you're doing a lot to help that with today's podcast. And certainly when you started at the very beginning, that was extremely helpful to understand this culture. I'm someone who's always looking ahead a little bit, and I'm very interested in research and new things. So are there promising new treatments or research findings in the area of PTSD, TBI, or sleep disorders that you're looking forward to?
So for PTSD, there's two that are on the radar. You probably know what I'm going to talk about, and it's the magic mushroom, or psilocybin.
Yes, of course.
And MDMA-assisted therapy. Right. So
exactly.
the psychedelic-assisted therapy. So those are the two that are on the horizon. Right now, the clinical practice guidelines are not for or against it. I think they're just waiting for the research to come out. And I really think it's very promising right now.
I do too. There's quite a bit of preliminary evidence, I have to say.
Yeah, I'm really hopeful.
Yeah.
For TBI, there's two that I found that are, I think, kind of promising, and that's the hyperbaric oxygen.
Yes,
and then you have the stem cell transplantation. So those are the two that I think are the most exciting that are coming forward in the literature. So I think we have a lot of exciting opportunities for us coming up with both mTBI and the PTSD.
Yeah. If I could just ask quickly, too, as far as TBI, what about anti-inflammatories, antioxidant treatments? There's a little bit of evidence on N-acetylcysteine, for instance, various other things. Fish oil has been, things like that. Are there other things, non-prescription, that make sense?
Yeah, there's a couple of things out there. So sometimes people use NAC or magnesium. Fish oil is very commonly prescribed. So when you go to see some of the TBI providers and they come back to see you in mental health, they're often on that cocktail. And I've seen that for probably 15, 20 years. And so there's some evidence that it is helpful. That information is out there as well.
Might help, can't hurt, right? Is what we like to say. Yeah. And then, of course, one area we didn't talk about is prescription digital therapies. Virtual reality, I know, is being used for PTSD, things like that. So I'm personally pretty interested in that kind of stuff, too. What are your thoughts about that? Digital therapies, interventions?
Right. So what's also interesting is, again, 15, now 20 years ago, I'm dating myself, at the NICO Center, they had this beautiful CARES unit. And so it's almost a 360 and they strap the individual in, and this is more for TBI and movement, but I think there's a lot of promise with these digital therapies in helping to rehabilitate individuals with both exposure and TBI.
Mm-hmm. Yeah, it's interesting that for PTSD and insomnia, and we've done a lot of education around this at NEI, there are some digital therapies that are FDA cleared. For instance, Nightwear is one, is out there. And then there's, of course, Somrist is the one for sleep, for insomnia. So there certainly are these other things. One last thing would be TMS. There's some data on TMS for PTSD. What are your thoughts there?
Yes. I actually looked at some of the data on the TMS with the PTSD. We have a TMS machine where I work now, and we're trying to get the okay to move forward with that in our clinic.
Oh, great. Yeah, that's great. And then ketamine and esketamine are somewhat controversial. Lori Davis told me that the data are kind of mixed, but anecdotally I've heard some people benefit from ketamine therapy, so that might be another one.
Yes.
Certainly if you're dealing with depression or treatment-resistant depression, okay. Well, we're getting close to the end of our time. This has been wonderful and fascinating and really helpful. And just finally for our audience, for the providers, and I want to tell you, there's a lot of lay people who listen to these podcasts too, and I hope they've also found this to be helpful. But for the providers, especially those maybe who are newer to working with veterans or want to understand this better, you mentioned a couple of resources, but what other resources or training opportunities would you recommend?
So there's a couple of places that they can go. One that is affiliated with Uniformed Services University of Health Sciences, that is the military university, is a place called Center for Deployment Psychology. And they have a lot of great training that's free. And it is, if you go to the website, you can get information on for military cultural competencies, but they also have evidence-based therapy for civilians that's free. So if you just go to the Center for Deployment Psychology and you look up training, there's a lot of availability there for civilian providers. And then there is the National Center for PTSD through the VA website. There's a lot of information there on PTSD, complex PTSD. And then there, for brain injury, it is the Traumatic Brain Injury Center of Excellence, and they have a lot of information on brain injury, facts, information, healthcare provider resources. And then there's brain.org, the Brain Injury Center for the military, and that's where there's a lot of information to include a large information on caregiver resources.
Well, that one's easy to remember, brain.org. I think I can remember that one. Yeah, and you'd mentioned earlier the National Center for PTSD and the VA website, all very, very helpful. So our time is coming to an end, Pam. I really want to thank you. This has been really eye-opening. So thank you so much. Okay, well, I want to thank everybody for listening. I hope you found this as enjoyable and educational as I certainly did. And of course, for more information about our other podcasts, you can go to our website, which is neiglobal.com. And there you can find information about podcasts and our other educational offerings, including our live meetings, our virtual meetings. And you can get these podcasts anywhere you get podcasts, including Spotify. What you look for is NEI Psycho Farm, or you can search my name, Cutler, because I'm indexed as the host. So thank you very much for listening. Thank you, Pam, for joining us today.
Thank you for having me. I appreciate being here.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.